Welcome, everyone. Today we're doing a focused review on laser physics and its applications in plastic surgery. This is really key knowledge for your board exams.
Exactly. We're going to dive deep into the fundamentals, the laser properties, tissue effects, and the clinical applications you'll need for revision.
Yes, especially thinking about exams like the FRCS plastics. We want to hit the essential information you need.
Right. So let's get straight into it. Laser physics fundamentals.
Okay, so light energy. It's got that dual nature, wave and particle, photon.
That's right. It acts as both. And the wavelengths, well, that determines the color of the light.
Wavelength being the distance between the wave crests.
And we group these into ranges. You've got ultraviolet, which is about 200, 400 nanometers.
Then visible light.
Visible is 400 to 750 millimeters.
Mhm.
Then near infrared, 750 to 1400 millimeters.
And finally, infrared, which goes much higher.
Yeah, 1400 up to 20,000 millimeters.
Okay, so how are the actual photons, the particles of light, created?
Well, it starts with an electron in an atom getting excited, moving to a higher energy level. When it drops back down to its stable orbit.
It releases energy.
Exactly, as a photon. Now, the really interesting part is stimulated emission.
Yes, the core of how a laser works.
Right. If that released photon hits another electron that's already excited, it stimulates that electron to drop down and release an identical photon.
Identical meaning same wavelength and crucially in phase.
Precisely, in phase, coherent. So you get this chain reaction. You pump energy into a lasing medium, could be solid, liquid, or gas.
Which excites the electrons in that medium.
Yes, and as they relax, they emit photons. These photons bounce between two mirrors. One mirror reflects fully, the other only partially.
So some light escapes through the partial mirror.
That's the laser beam.
Okay.
But inside, the light gets amplified as more and more in-phase photons are generated. And that gives us the acronym AZER.
Light amplification by the stimulated emission of radiation. Makes sense. The key bits are the medium, the pump source, and the mirrors.
Correct. Pump source could be a flash lamp, electricity, even another laser.
Okay, so this laser light, what makes it so special compared to, say, a light bulb? The defining characteristics.
Three key things. Coherence. The waves are all synchronized in phase. Monochromatism, it's essentially a single color, a single wavelength.
And collimation.
Collimation. The beam stays tight and parallel over distance. It doesn't spread out much. This is very different from something like IPL, intense pulse light, which is non-coherent.
Right, IPL is more like a filtered flash lamp, not a true laser.
Exactly. Less focused energy.
We also hear a few other terms. Can you quickly define excimer laser?
Sure. Excimer lasers use molecules, like dimers, that only exist stably in an excited state. They're short-lived.
And a chromophore.
A chromophore is the part of a molecule that absorbs light and gives it color. It absorbs specific wavelength. Think melanin, hemoglobin.
The targets, essentially. And a flash lamp.
That's just a device, often a tube filled with gas like xenon, that produces very bright, short pulses of light, often used as the pump source for certain lasers.
Got it. Okay, let's shift to the clinical side. What are the crucial laser properties we need to understand for applying them?
Wavelength is absolutely number one. It dictates how deep the laser penetrates the tissue.
And longer wavelengths penetrate deeper, generally?
Generally, yes. Within that sort of therapeutic window of 400 to 1400 nanometers, deeper penetration. It relates to the tissue's absorption length for that wavelength.
And spot size matters, too.
A larger spot size can help achieve the maximum absorption for that wavelength and can also increase the depth of penetration slightly due to scattering effects.
Okay. Then there's energy density, or fluence.
Right. That's the energy delivered per unit area, usually joules per square centimeter, JCM.
And power, though perhaps less commonly adjusted directly in some settings.
Power is relevant, yes, but often we think more in terms of fluence and pulse width.
Ah, pulse width, duration of action. This seems critical.
It is absolutely critical. You need to match the pulse width to the target's thermal relaxation time, or TRT.
TRT, that's the time it takes for the target to cool down, right? Lose half its heat.
Essentially, yes. Time to dissipate about 51% of the absorbed energy. You need to deliver the laser energy faster than the target can cool.
Otherwise, the heat just leaks away without causing the desired effect.
Exactly. And the TRT is proportional to the square of the target's diameter. Bigger things take longer to cool.
So tiny targets like pigment granules need very short pulses.
Very short. Nanoseconds or even picoseconds. Whereas larger structures like blood vessels need longer pulses, milliseconds perhaps.
Continuous wave lasers are generally avoided.
Mostly, yes. Too much nonspecific heating, high risk of scarring. Pulse delivery is key for targeting.
What about Q-switched lasers? They have extremely short pulses, don't they?
Extremely short nanoseconds and picoseconds. They deliver massive energy bursts that create a photoacoustic effect, like a shock wave.
Which shatters small particles.
Exactly. Great for tattoo pigment, melanin granules. But a point of caution.
Yeah.
Be careful using them in patients with rheumatoid arthritis who are on systemic gold therapy.
Interesting point. Is there a rule of thumb for pulse duration relative to TRT?
A useful tip is that the ideal pulse time is often around half the TRT of the target structure.
Okay, so we have the physics, the properties.
Sure.
How does the light actually interact with tissue?
4 possibilities when light hits tissue: reflection, scattering, transmission.
Or absorption? And absorption is what we want, usually.
Yes. We rely on selective photothermolysis. You choose a wavelength that your target chromophore absorbs strongly.
Like hemoglobin for blood vessels or melanin for pigment?
Right. And you deliver enough energy quickly enough to heat that target selectively, damaging it while ideally sparing the surrounding tissue.
And the heat causes specific effects depending on the temperature reached.
Around 60, 70 degrees Celsius, you get coagulation, protein denaturation. Get up to 100 degrees, and you get vaporization, boiling the water in the tissue.
And usually it takes multiple sessions to get the final result.
Almost always, yes. Gradual improvement is typical.
Right, let's get into the specifics, applications. Starting with vascular lesions, what's the target chromophore?
Hemoglobin, both oxy and deoxyhemoglobin. They have absorption peaks we can target, like 532 millimeter, 577, 600 millimeters, and also in the near-infrared range.
And the goal is to damage the vessel.
Damage the vessel intima, cause the collagen around it to contract, and ultimately lead to flow stasis or thrombosis.
What lasers are typically used?
A range: KTP at 532 millimeter, pulse dye lasers, PDL, around 585 or 600 millimeter, Alexandrite 755, diode lasers at various wavelengths like 800, 810, 940, 980.
NDYAG 164 millimeter.
Yes, and IPL can also be used, covering a broad spectrum from 400 to 1300 millimeter.
Can you give examples for specific conditions, say hemangiomas?
And DIAG is sometimes used, maybe for early, ulcerated, or regressing ones, but it's generally contraindicated in the proliferative phase risk of necrosis.
Okay, capillary vascular malformations like port wine stains.
Pulsed yellow dye laser is a common choice, also IPL. Success depends on factors like patient age, lesion color lighter responds better skin type, ideally I3.
And location matters.
Yes, head and neck generally respond better than extremities, though maybe not V2 distribution. Extremities are often tougher.
What about deeper malformations, venous or venal lymphatic?
NYAG is often used, sometimes intralesionally or combined with surgery or sclerotherapy. Need to be careful with prolonged energy delivery due to scarring risk, although areas like the lips can be more forgiving.
Facial telangiectasia, says rosacea.
KTP, pulse dye, diode, and DYAG are all options. They tend to be less effective for the really tiny vessels or very large ones, and sometimes tricky on the nasal tip or allay.
Spider veins on the legs.
Similar lasers,
Yeah.
KTP, PDL, Alexandrite, diode, and DOYAG is quite common, IPL2. Crucially, you need to address any underlying venous insufficiency first.
Right. Laser is more for the superficial fine vessels or perhaps areas prone to ulceration with sclerotherapy or if someone's allergic to sclerosens.
Exactly. And sometimes combining wavelengths like 532 and 164 millimeter might give better results.
Okay, let's switch gears to pigmented skin lesions. The target here is melanin.
Melanin is the primary target. It absorbs across a broad spectrum, but we often favor longer wavelengths for better penetration and maybe less competitive absorption by hemoglobin, even though melanin absorption itself decreases at longer wavelengths.
And the effect is breaking up the pigment?
Fragmentation of melanin, which is then cleared by the body or sometimes exfoliated.
Lasers used.
Again, a variety. KTP 532, Ruby 694, Q-switched and long-pulsed. Alexandrite 755, Q-switched and long-pulsed. Diode 800, NDYAG 164, especially Q-switched. Even ablative lasers like AIR-YAG and CO2, fractional lasers, and IPL.
What sort of lesions are treated?
Things like lentigines, seborrheic keratoses, freckles, ephelides. Café au lait macules can be treated, but recurrence is high.
Becker's nevis.
For Becker's, you might use a Q-switch laser like Ruby for the pigment and a long-pulsed laser for the associated hair. Melasma treatment is tricky, needs real caution.
Congenital nephi.
Treatment is controversial, generally not recommended due to concerns about malignant potential and incomplete removal. Nevus, Avoda, and Ito are also treatable indications.
Hair removal, another big application. Target is melanin again?
Yes, melanin in the hair follicle and shaft. Common lasers are diode around 800 millimeter, Alexandrite 755 millimeter, and D.YAG 1064 millimeter. IPL can also work, sometimes better for fairer hair.
Best results usually on.
Fair skin and dark hair. That combination gives the best differential absorption. And you need to target hair in the anagen or growing phase.
Makes sense. Tattoo removal. Very common now.
Yes, here the targets are the exogenous tattoo pigments. We primarily use Q-switched lasers.
Because of that photoacoustic effect shattering the pigment particles.
Exactly. The rapid heating creates acoustic waves that mechanically break up the pigment into smaller pieces for macrophages to engulf and clear.
Which Q-switched lasers?
Ruby 694mm, Alexandrite 755mm, and NDYAG, which has two useful wavelengths, 164mm for dark inks and 532mm for red inks.
Any precautions?
Avoid treating tan skin if possible, as the melanin competes for absorption, increasing risk of side effects, though NDYAG 1064 is generally safer on darker or tan skin.
And different colors need different lasers.
Yes. Dark inks like black and dark blue respond well to most, but 1064 ND-BIAG is often preferred. Green ink often needs Alexandrite or ruby. Red ink responds well to the 532mm ND-BIAG. Yellows and oranges can be quite resistant.
What about using lasers for scars?
For scars, particularly erythematous or hypertrophic ones, the target is often oxyhemoglobin in the small blood vessels within the scar.
So, similar to vascular treatments?
Somewhat, yes.
Well,
Lasers like pulse dye, 585 595mm, or ND-BIAG 532-1064mm are used. The proposed effects include coagulation and necrosis of microvessels, maybe reducing fibroblast activity, increasing collagenase, MMP13, and reducing type 3 collagen deposition.
used for hypertrophic scars, keloids, burn scars.
Yes, pulse dye is quite commonly used for those, aiming to reduce redness and sometimes improve texture and pliability.
Okay, skin resurfacing. Big topic. What's the target here?
Water. Intracellular and extracellular water is the main chromophore for the common resurfacing lasers like CO2 and erbium-YAG.
And the effects are quite broad.
Yes, you stimulate wound healing responses. Angiogenesis, new collagen formation, neocollagenesis, elastic fiber regeneration. Penetration is usually to the upper reticular dermis.
How does it compare to chemical peels?
Effects can be similar to a medium depth or even deep peel like phenol, depending on the laser and settings. An advantage is often less effect on pigment cells compared to deep peels, so potentially less risk of permanent hypopigmentation. Melanocyte function is often retained.
There are different approaches, non-ablative and ablative.
Correct. Non-ablative resurfacing heats the dermis and or epidermis to stimulate healing without removing tissue layers. Ablative lasers actually vaporize tissue layers.
Examples of ablative lasers.
CO2 at 10,600mm and erbium.YAG at 2,940mm are the main ones. There's also fractional resurfacing, which creates microscopic columns of ablation or coagulation, leaving surrounding skin intact.
How do CO2 and erbium compare?
CO2 causes more thermal injury relative to ablation. This leads to significant tissue contraction, often long-lasting results, but also longer recovery, more redness, and a higher risk of hypopigmentation or scarring.
And erbium.
YAG has a much higher affinity for water, so it's more purely ablative with less residual thermal damage. This means more precise depth control, generally safer, better for thinner skin areas, shorter recovery, less prolonged erythema.
What's the endpoint when doing CO2 resurfacing?
You look for a chamois yellow color after wiping away the ablated tissue, indicating you're in the papillary dermis. Going deeper increases risks.
And the indications for resurfacing.
Wrinkles, rhytids, uneven pigmentation, dyschromia, certain types of scars like acne scars, and general texture abnormalities.
Any important pretreatment considerations?
Often, pretreatment with hydroquinone and or tretinoin for 4-6 weeks can help prevent post-inflammatory hyperpigmentation. Crucially, oral isotretinoin should be discontinued for at least 6 months, sometimes a year, before ablative resurfacing due to impaired healing and scarring risk.
Topical tretinoin is okay, though.
Topical tretinoin is generally not considered a contraindication and is often part of pretreatment. Also, antiviral prophylaxis, usually with valacyclovir or acyclovir, is standard for full-phase ablative resurfacing, and recommended for non-ablative too, if there's a history of herpes simplex.
Good point. Briefly, laser liposuction.
Yeah, this uses lasers, often NDEAG 164mm, sometimes diode 980mm, or combined 1064-1 320mm, inserted via cannula. The target is water and fat.
Proposed effects.
Rupturing adipocytes, coagulating small blood vessels, and heating dermal collagen, potentially causing tightening.
Is it proven better than standard liposuction?
There's currently insufficient high-quality evidence to say it's significantly more effective overall.
Potential advantages and disadvantages.
Hypothesized advantages include maybe less blood loss, the collagen tightening effect, and potential use in difficult fibrotic areas.
Hmm.
Disadvantages include longer operating time, equipment cost, a learning curve, and the risk of thermal injury or burns if not done carefully.
Okay, let's talk complications across all these applications. What are some common or important ones?
Well, some things are expected, like purpura after pulse dye laser. But true complications include post-inflammatory hyperpigmentation, PIH.
PAH is quite common.
Yes, especially in darker skin types or with recent sun exposure. It typically appears weeks to months after treatment, maybe 6 weeks to 6 months, and usually fades over time. Hydroquinone can help treat it.
What about hypopigmentation? Lighter spots.
Hypopigmentation can also occur sometimes due to melanin absorption by shorter wavelengths, especially if treating pigment or on darker skin. It often has a later onset than PIH. Using longer wavelengths, like ND-IAG 1064, can reduce this risk in darker skin.
Starring.
Hypertrophic scarring is a risk, particularly if treating too aggressively or in patients with risk factors, like recent oral isotretinoin use.
Infections.
Herpes simplex reactivation is a significant concern with facial resurfacing, even with prophylaxis. If you suspect it, do a Zank smear or viral culture and increase the antiviral dose. Bacterial or fungal infections are less common, but possible.
Any others around the eyes?
Lid retraction and ectropion are known risks with periorbital resurfacing, if not performed carefully.
And a weird one with tattoo.
Paradoxical darkening. Some cosmetic tattoos, especially flesh-toned pink or white ones containing iron oxide, ferric oxide, can turn black or gray when lasered as the iron is reduced to ferrous oxide. This can be difficult to remove subsequently.
So, key takeaway on pigmentation issues. Hyperpigmentation usually shows up earlier than hypopigmentation.
That's a useful distinction to remember, yes.
Safety is paramount with lasers. What are the key considerations?
Starts with proper patient evaluation by the physician. Personnel using lasers need appropriate training and accreditation.
Who should perform which procedures?
Invasive procedures like full ablative CO2 or erbium resurfacing should definitely be performed by a properly trained physician. Regulations vary by state or country regarding supervision requirements if non-physicians operate lasers. Often, physician on-site presence is required.
What about the physical setup? Eye protection.
Absolutely crucial. Laser-specific eye protection must be worn by everyone in the room, including the patient. The patient's eye should be fully protected, often with opaque metal shields, isolating the entire orbit.
Windows, airway, fire risk.
Windows need opaque coverings. For CO2 lasers especially, use wet drapes around the treatment area and protect adjacent structures with metal guards. If general anesthesia is used, a laser-safe endotracheal tube is needed, and inspired oxygen concentration, FiO2, should be kept low, typically below 30%, to minimize fire risk.
Clue evacuation.
Yes, especially with ablative lasers like erbium and CO2, which create a plume of vaporized tissue containing potentially infectious particles and chemicals. A smoke evacuator with an ultra-low particulate air ULPA filter is essential.
And skin cooling. Why is that used?
Skin cooling protects the epidermis from excessive heat, reducing pain and minimizing the risk of burns or pigmentary changes, especially when targeting deeper structures. Various methods. Contact cooling with a chilled sapphire or metal tip on the handpiece, cold gel applied to the skin, cold air blown onto the area, or cryogen spray delivered just before or after the laser pulse. The timing relative to the laser pulse is important.
Okay, let's try to summarize some absolute key points for exam revision. CO2 laser's main target.
Water.
Most common infection after facial resurfacing.
Herpes simplex reactivation. Remember prophylaxis.
Which common laser has the deepest penetration and potentially the lowest risk of hypopigmentation for things like tattoo removal in darker skin?
Q-switched ND.YAG 264 mm.
Absolute contraindication to resurfacing we discussed.
Recent oral isotretinoin use within 6-12 months.
Current standard approach for tattoo removal.
Using specific Q-switch lasers that target the pigment wavelengths present in the tattoo.
And comparing air YAG and CO2 affinity for water.
Air YAG is the highest affinity for water, much higher than CO2, making it more purely ablative. CO2 still targets water effectively, just with more associated thermal effect.
Excellent. This has been a really thorough review of laser physics and its plastic surgery applications geared towards board preparation.
Hopefully covering those fundamental principles, properties, tissue interactions, and the clinical uses has solidified the key details for effective revision.
Absolutely. Understanding these core concepts is just fundamental for exams and, of course, for safe and effective practice.
Definitely.
So maybe a final thought for you to consider. Looking ahead, how might advancements in laser technology, maybe new wavelengths, new delivery systems, further refine our ability to selectively target tissues and improve patient outcomes even more? Something to think about.